organizing team of this E3 Con for this invitation. So I stand before you today to speak on ultrasound-based management of a rhesus isoimmunized pregnancy. But I will also take this opportunity to address a few things about rhesus isoimmunization because I am currently chairing the perinatology committee of FOXI, and one of the flagship programs that we have taken on in this year is prevention of rhesus isoimmunization and educating everybody about rhesus isoimmunization because it's a very preventable condition. So this is not unusual for some of the senior obstetricians who are practicing here, and it's very sad that even today we see some patients like this, where the first child was born uneventful, next time there was some issues with jaundice, they may have had the baby or lost the baby or some neurodevelopmental delay, and subsequently a woman continues losing many pregnancies because of high drops. And this used to go undiagnosed, and I'm telling you, even today, people are even doing genetic tests mindlessly on these patients without realizing that the neurodevelopmental problem was because of jaundice, not because of genetics. And this was the condition which we used to initially read in textbooks. Thankfully, the condition has become lesser, but it is hemolytic disease of fetus and newborn. Ideally, in 21st century, we should not be having this condition because it's a completely preventable condition. Historically, hemolytic disease of fetal and newborn was very important, and in the beginning of the 20th century, we are now in the 21st century, so about 120 years back, this was the information given in scientific papers where they said 10% of perinatal deaths are because of rhesus related problems. And there is a lot of literature to support what I am saying. And this rhesus factor, we all know, we read about it in physiology. When we do blood group typing, you just don't do A, B, O, you also add positive or negative. And that RH comes from the rhesus macaque monkeys from whom this factor was first seen. So basically, people who have the D antigen on the red blood cells are known as rhesus positive, and those who do not have the antigen are known as rhesus negative. Now, one important difference between ABO and rhesus. What is that important difference? In ABO, there are two things. There are antigens and antibodies. So a person who is A positive, or forget positive, who is a person who is A has the A antigen, but it also has anti-B antibodies, naturally. Whereas a person who is B has B antigen and has anti-A antibodies, and that's how it works. But a person who is rhesus positive has the rhesus antigen and obviously no antibodies. A person who is rhesus negative, listen carefully, a person who is rhesus negative neither has the antigen nor the antibodies. So rhesus antibodies are not naturally found in human beings. Agreed? Nature does not make this naturally. How do these antibodies get made? Whenever a rhesus negative person is encountered by rhesus positive blood, then he or she can make antibodies. So that is the pharmacological anti-D that you get, that is prepared by giving voluntary donors. There are people who are rhesus negative who are injected rhesus positive blood so that they make the antibodies. If these people are men, it does not matter because these antibodies are not harmful to them and they'll never get pregnant, so it's not a problem. But if a woman who is rhesus negative develops antibodies against rhesus positive blood and she has a fetus who is rhesus positive, then the whole problem starts. And that is why when a rhesus negative woman develops the antibodies, then there will be a problem to the fetus. How do we detect these antibodies? The woman is rhesus negative and she is ICT positive, indirect Coombs test positive. Therefore, if you are an obstetrician treating women, first you should know their blood group. Please accept the fact that everybody needs a blood group test. I do pure fetal medicine, and even at 20, 24, 25 weeks, even after IVF, I have received patients who do not know their blood group. We do not take a patient in for scan in our clinic unless the blood group is confirmed. So I have had at least 3 patients in the last 15-20 years who have walked out of my clinic because they said, we'll not have the blood group test because our doctor did not send for blood group test. I said, I am not giving a scan report unless I know your blood group. So they said, we'll not have the scan here. I said, bye-bye. Because it's not a good practice for an obstetrician also to not know the blood group till 20-25 years. But that happens. If she is rhesus negative, then an ICT should be done. How many of you agree that every rhesus negative woman should have the ICT done at booking? Okay, thank you. How many of you think it is only necessary if she is a multigravida, not in a primigravida? How many of you will not do an ICT for a primigravida? Some of you. Because you think it is not needed. Ideally, a primigravida should not have any antibodies because they don't naturally have the antibodies. But as an obstetrician, why are you taking that risk? If tomorrow she is ICT positive and she says, I became ICT positive under your watch, why do you want to take that risk? So it is a good idea for you to do an ICT in any woman who is rhesus positive at the time of receiving that woman. Because you should, if she already has the antibodies, she has got it from somewhere, she has to be doing. A lot of people have over-the-counter MTP pills and they never tell anyone. And if they have had that, they could be ICT positive by their own self. They could have had mismanaged antibodies, or they could have had blood transfusion which is mismatched, or they could have any other antibody other than anti-D which also gives ICT false positive. So we should do an ICT for everybody who is rhesus positive. So any woman who is pregnant for the first time, if she is rhesus negative and she does not have the antibody, she will not have any problem. If she is rhesus negative but she does not have any antibody, any number of pregnancies, she won't have a problem. If a woman has ICT positive, she has antibodies, but the fetus inside is rhesus negative, then also she will not have any problem. But if she is isoimmunized and the fetus inside is rhesus positive, then the fetus is at risk of developing hemolytic disease of fetus and newborn. So this is the combination that you need to watch out for. The mother is rhesus negative in all cases, the father is rhesus positive. The father can be either homozygous positive or heterozygous positive. If he is homozygous positive, that means both his genes are plus plus, then all the children will be rhesus positive, and therefore all fetuses will be at risk of hemolytic disease if she is ICT positive. If the father is heterozygous, then half of the children may be negative also. Now this is complicated. How many of us find it easy? How many of you know that we can do the genotype of the father? Very difficult. And if we do also, where? We know that we can do it, but we don't know where, because all the labs say, let them come to the lab and give the sample. And the lab is in Delhi. How will you send the patient to Delhi just to get a genotype done? So all that was very difficult. So we found out better methods of managing ICT, managing women with rhesus negative status. So most important thing, check them for antibodies. If they don't have antibodies, they are like any other woman, don't worry. If they have antibodies, then you need to worry what are these antibodies. If they have antibodies, then the role of fetal medicine specialist comes, because this woman needs to be screened for fetal anemia. What will these antibodies do? They will go through the placenta and they will kill the red blood cells of the fetus. So fetus will develop hemolytic anemia, and we should be able to detect that anemia. So when should we check for ICT? At the time of booking, and again at the time of 28 weeks, and then after birth, if the baby is rhesus positive, you give the woman anti-D. Antenatal anti-D can be given if ICT at 28 weeks is negative. That means she is still not isoimmunized, but to prevent isoimmunization in pregnancy, you can give the anti-D. At the time of delivery, these are some precautions. I have just put this slide because all of you are obstetricians. Some of you can remember that these are some basic precautions that have been taught to handle a rhesus negative pregnancy. Assuming that she is at risk of feto-maternal hemorrhage, you don't give an oxytocin before the placenta separates. You don't, try and do manual removal of the placenta. You keep the cord a long length and send it for all the DCT, ABO, rhesus typing and bilirubin. These are the potential sensitizing events in pregnancy, after which anti-D injection should be given externally. So I was part of the guideline making committee of FOXI, which prepared the India-specific guidelines for rhesus isoimmunization. And one of the first things that they have suggested is every woman at the time of booking should have blood group and ICT done. What is ICT? Before we go into the ultrasound, what is ICT? ICT is a test for antibodies. And ICT tells you that she is ICT positive or negative. That means it is a qualitative test. What is positive? Antibody. But which antibody you don't know. You are assuming it is anti-D antibody. But there you can also do typing of the ICT to find out which antibody is positive. Also, if you want to get the titers, how do the titers come? 1 in 8, 1 in 16, 1 in 32. Have you heard of it? Now tell me, 1 in 32 has more antibody or 1 in 64 has more antibody? All those who think 1 in 32 has more antibody than 1 in 64, please raise your hands. 1 in 32 has more antibody than 1 in 64. These are math students because they feel that the numerical value of 1 in 32 is more than 1 in 64, isn't it? 1 by 32 is numerically more than 1 by 64. This answer is correct in maths, but in biology, 1 in 64 is more than 1 in 32. I will tell you how. Because ICT is a dilution test. So if you have to dilute the sample n number of times for the sample to become negative, then it is 1 in n. So if you have to dilute a sample 32 times and the sample becomes negative, it has this much antibody. But if you have to dilute it 64 times and then it becomes negative, then the amount of antibody is more or less? More. So 1 in 64 is more than 1 in 32. So if you get a report of 1 in 2, you can even ignore it because sometimes it's just false positive or old antibody. But don't ignore it. But I'm just telling you. So if an ICT is positive, pay attention. But 1 in 64 is more than 1 in 16. 1 in 2 is less than 1 in 16. Understood? So ICT you've understood now. And you also do the 11 cell panel because sometimes women are ICT positive, but they say they have not received any anti-D, they say they have no other problem. So you type the antibody. Sometimes you will find unusual antibodies. We recently have a patient who has a IgM of a different variety positive. Her anti-D is negative. So she is ICT positive, but we still have to give her anti-D because she is not D positive. So these are things, but once she is ICT positive, send it to these fetal medicine people. No, what are they doing? They need some cases, so send them all the ICT positive cases. But please understand that ICT positive is an important condition. And you look for all the different types of antibodies. When women were ICT positive, so many things were done in the past. You tried to check the father's genetic status, you tried to do the fetus genetic status, you tried to do spectral analysis of the amniotic fluid. That means you did amniocentesis, took out the amniotic fluid and saw that in a spectrophotometer to see whether bilirubin is there in that amniotic fluid. All that is past now. Now we don't do all that. Now we do only ultrasound. Ultrasound of the fetus for a specific vessel, that is the middle cerebral artery, because the middle cerebral artery peak systolic velocity will tell us whether or not the fetus has anemia. And what are we looking for? We are looking only for anemia. So ultrasound management of rhesus isoimmunized pregnancy is based on measurement of the middle cerebral artery peak systolic velocity, which should start from 16 weeks. I don't know if they can do it any faster in Kurnool, but I think we do 16 weeks, isn't it? No, nowadays youngsters are doing everything in first trimester, but we don't do it in first trimester. The nomograms are available all after 16 weeks. And earlier, how many people remember Lilly's chart? Lilly's chart. What was Lilly's chart? Lilly's chart was optical density of the amniotic fluid. So that was amniocentesis, checking it in spectrophotometer. And if the OD was, anybody can tell me what was the OD critical at that time? 450 nanometers. Whoever said must have topped the PG exam, no? 450 nanometers because that is the range for yellow. So it used to be turning yellow at that point. But now we don't do Lilly's chart. Lilly's chart has been replaced by this chart, which is known as the Mare's chart. Giancarlo Mare was the scientist who discovered this role of middle cerebral artery. And why this velocity is so important? Because the middle cerebral artery is a very, very easy, sort of vessel to investigate, and we can get the exact angle. In very mild anemia, there will not be that much changes. In very severe anemia also, it might fail. But by the time there is severe anemia, you will have other methods. No, there will be hydrops in the fetus will look compromised. But that moderate anemia, which can be treated, that will be very well picked up by the middle cerebral artery. So you look at the artery in the long axis and you put the your pulse wave Doppler anywhere between the proximal 1/3 and the distal 2/3 of the vessel, and try and cover. You see where that gate is? It is right in the middle of the vessel. Every one of you tomorrow, if you go and try, will not be able to do it, because it requires a certain degree of skill and expertise and practice. So if you do it on your own and you get some value and you scare the patient, you're doing harm. So if you want to do it, do constant practice and then you will get there. So then we look at the peak systolic velocity. It's a simple measurement. It's not a PI, it's not a ratio, it's not an index. It's just the peak systolic velocity. And this velocity should not be more than twice of the gestational age in weeks. So suppose she is 20 weeks, you don't expect a PSV more than 40. If she is 32 weeks, you don't expect it more than 64. So if you don't have a software with you, just do a proper dating of the fetus and do the middle cerebral artery Doppler, and if the velocity is less than twice the gestational age in weeks, then she is unlikely to be anemic. And then once you, so it's not very difficult to do it. You can see a structure called the circle of Willis, and that guides you to the middle cerebral artery, and with adequate magnification and placing of your cursor, you will get the exact picture of the middle cerebral artery. The angle is very important because you are measuring a velocity. So if you go here and there somewhere, you won't get the best velocity of the jet. So these are the pictures of middle cerebral artery Dopplers, and then you plot them in the nomogram, and that is above the 95th centile. You see, for this fetus, this is where the value is. So this is more than 95th centile for that stage of gestation, and it is 100% sensitive for fetal anemia. So if a fetus has a high middle cerebral artery Doppler PSV, you can plan your fetal anemia treatment based on this. You don't need to do a blood sampling to confirm the anemia. You can start planning for the transfusion. So earlier we used to look at the dilutions, but more than dilutions, now we check the middle cerebral artery. So this is a patient, she's gravida 3, para 2, L1, D1. She's lost one child for hydrops at 28 weeks, cause not known. And in this pregnancy, she's found to be ICT positive. So here you see, when she's come to us, the middle cerebral artery Doppler is more than 95th centile of gestation. That means this fetus is also going into anemia. If we don't treat this patient, the patient will land up again in hydrops, and you think it is 27 weeks, I have a good NICU, let me deliver this way. This is not a typical premature baby. This is an anemic premature baby, and an anemic premature baby is more difficult to handle than a regular premature baby. So this is not just anybody whom you can just give steroids and deliver. You have to correct the anemia first, and the method of correcting the anemia is to calculate how much blood will be required. There are different ways of finding out how much blood is required. And what is the blood that we used? We used leukodepleted. Those blood cells should not have any white blood cells. So leukodepleted, gamma irradiated, so that any other infections and other immune reaction causing things have been removed out. You don't have any CMV infection, you don't have anything which can cause a graft versus host reaction. O negative red blood cell, whatever the blood group of the baby, O negative is universal donor, and here you are dealing with rhesus antibodies, so you give O negative blood, and in a special pack which has a high hematocrit. and then you use ultrasound to find out where you are going to actually give the transfusion. So in this case, you can see it is an anterior placenta. The placenta is towards us. So we look at the place of the cord insertion of the placenta, and then you guide your needle into the cord insertion, and finally you inject. When you inject blood in the correct place, you can see the blood streaming into the umbilical vein. And once you do that correction, immediately you will see the middle cerebral artery peak systolic velocity drop from above the 95th centile to well within normal range. So this is instant like result of your treatment. This is how the blood is produced and prepared, and this is how transfusion is done. So immediately after the transfusion, you will see that the MCA velocity, so ultrasound helps in not only guiding you the need of treatment, but also in monitoring the result of the treatment. So the peak systolic velocity has come down to normal. If it's a posterior placenta, we sometimes use the portal vein, and in any case, whatever you do, you should see that post-transfusion it has come down. This was another patient. Just look at her. How many pregnancies has she had? Gravida 7, and so many losses, only one live child, and each of them because of this. She came to us at 23 weeks 4 days. At 23 weeks 4 days, when we detected fetal anemia, the pre-transfusion hemoglobin was 2.8 grams. And mind you, this is not the lowest. The last one we did recently, 0.3 grams. It was a completely hydropic fetus. We couldn't even do the blood group of that baby. But she went on and delivered at 36 weeks and had an 11 gram hemoglobin. Again, this one till 31 weeks we could pull, but 31 weeks the pre-transfusion hemoglobin was again 3.8, and we did another transfusion at 31 weeks and she went on and delivered. So when do you deliver these patients? Anytime after 34 weeks is good, but if you can pull them to 36 or 37 weeks. This was a Somalian woman who had come to us. She was gravida 9 with only one live birth, and she had this baby after I think 14 years. And she has named that baby Indo because she got it in India, so she calls it Indo. So in rhesus isoimmunization, your ultrasound will help you in diagnosing the anemia. It will also help you in planning the treatment. But please remember, the success of fetal medicine is not in the number of transfusions that we do. The success of fetal medicine is not having to do any transfusion, at least for this, because this is a preventable condition. So if we are boasting, I am doing so many transfusions, that is not a compliment. That is a shame on the level of preventable obstetrics that we have. So we should be able to prevent this condition. Any case where you are seeing a pregnant woman who's rhesus negative, please do the ICT, look for sensitizing events, and protect her by giving her anti-D timely. When do you give the anti-D? So this is anti-D, and this is nothing but the same antibody which a woman can produce. But when you give it from outside, what happens? The moment fetal blood cells come into the maternal circulation, these antibodies block them, and they are not able to react with the maternal immune system. So the mother remains protected. After some time, they will go away, and then the mother will be safe. So look at this statement. The prevention of rhesus D and anti-isoimmunization in higher income countries remains one of the most important medical accomplishments of the last century. And we are lucky to have it, because when it was not there, there was no option. There are royal families which have broken because of this condition. Because the queen was not able to have an heir, the Church of England had to divide, because the king wanted to marry another woman and he could not marry till the church changed its laws. So this is a very, very important disease, and please pay attention. So within 72 hours of the sensitizing event, you can give anti-D, and if you give routine antenatal and postnatal anti-D, your reduction in isoimmunization comes down to 90%. But if you give antenatal as well as postnatal, the reduction is 99.8%. So giving antenatal anti-D is also useful. Document your anti-D, place it the counterfoil in her notes, and remember, anti-D is an intramuscular injection, but it is always given in the which muscle? Deltoid. Have you paid attention to this? How many of you insist that it is given in the deltoid? I'm glad, because in most places nobody remembers, because most of the injections are given by nurses and paramedics, and they all prefer giving it in the gluteal because it's the easiest place to take. Our women wear blouses. It's difficult to remove the blouse before taking an injection. So even if you want to give it in deltoid, you'll say it's okay. I'll finish it like this and you go. So please remember that it has to be given in the deltoid, not in the gluteal. And in the future, maybe there will be a time when we can do what is written here. This is called plasmapheresis. If you have a woman who is strongly ICT positive, you can use something like dialysis, a plasmapheresis, to clean the antibodies and make her safe for pregnancy. But each treatment will cost her some 20 lakh rupees. So as of now, I don't think it's something which we can do. It's something for the future. And there is another thing that is called fetal rhesus typing that is available now. Suppose a woman is ICT positive, you want to know whether this fetus is rhesus negative or positive, you can do NIPT for fetal rhesus typing. But it can be false positive or negative, so therefore if it is rhesus positive, it gives you a reason to definitely follow that pregnancy. If it is rhesus negative, be careful, but don't give up on the pregnancy completely. IVIG can be given to prevent or delay the transfusion. In AIMS they did a study where in transfusion only they gave IVIG, but it's all very experimental. So my final take home message is prevention is definitely better than cure. So try your best to prevent rhesus isoimmunization and learn from your mistakes yesterday, live today and practice for tomorrow. Now whatever I have told you, if it has generated any interest in rhesus isoimmunization, I request all of you to scan this QR code, or I will send the details to Radha Lakshmi madam and she will circulate it with all the delegates. This is a free course. This is a free master class being done by FOXY as a FOXY BSV initiative under the Perinatology Committee activities this year. And I have to thank our President Dr. Jaideep Tank for taking this initiative and giving us the opportunity to conduct it. There are 4 lectures in this master class. One is Introduction to the Blood Groups and the Rhesus Overview. One is Preventing Rhesus Isoimmunization. One is Managing Rhesus Isoimmunization. And one is about Pathophysiology. So there are 4 experts from 4 parts of the country. I am representing South. Dr. Kushagrati Ghosh is from Kolkata. Dr. Vandana Bansal is from Mumbai. And Dr. Aparna Sharma is from Delhi. So all 4 of us have got together and we are doing this together. And just enter this. And I also have to announce, I will send both the details to madam. She can update it in the group, that there are 2 things happening. One is this master class. This is free. If you complete the master class, you get a certificate with the ICOG points, 3 ICOG points. And if you do a essay competition, that is for the PGs, all the medical college PGs, please share it. If you win a prize, your AICOG registration will be done or reimbursed. And everything, your travel, stay, everything will get done or reimbursed. So it's a very attractive prize that BS